Well, experts say if you're having unprotected sex in Saskatchewan, you're at risk. The province has the highest rate of new HIV cases in the country, and the numbers are moving in the wrong direction, especially for women of childbearing age, according to one organization. Now, behind the statistics are stories of stigma, survival, and solutions. Today, we're pulling back the curtain on Saskatchewan's HIV crisis. You can call and email us with your thoughts on what you're hearing today, 1-800-716-2221. You can also email bluesky@cbc.ca. We do have the highest HIV rates in the country, while globally rates are decreasing. Starla Pelche remembers getting the diagnosis.
I got really sick. I'm pretty sure I was dying. And the doctor, it wasn't the greatest. I was diagnosed at the hospital, and he had basically come back and he had said that, all my tests were looking good, and was getting ready to walk out that door. And just as he turned around and he said, "Oh, by the way, you tested positive for HIV," and then left. He walked out, and I was kind of sat there I didn't know what to think. I felt this small after. I can remember telling my mom that I was, if I ever caught it, I'd probably end my life, because I didn't know anything about it, and there's that big stigma on it, right? But I mean, obviously that's changed because for the better. At the same time, it saved my life because it brought me home. And I got myself, better with the right supports and going to school, and I have children. That's my reason too. They can't be in this world without me, that's for sure.
That is Starla Pelche, who lives here in Saskatoon. One of the organizations trying to help tackle this massive issue is Sanctum Care Group. The nonprofit works with people affected by HIV, homelessness, mental health issues, and more. Caitlin Roberts is the executive director of Sanctum Care Group, and she's here with us in studio to listen to so many different perspectives on this really tough issue. Caitlin, welcome to Blue Sky.
Thank you for having me.
To listen to Starla like that, I'm wondering what's running through your mind.
Well, I think Starla's story rings true for many people who are diagnosed with HIV in our community. Certainly there is a lot of stigma associated with it. And unfortunately, we're not always the best at delivering the right care and support when someone is diagnosed with HIV. And unfortunately, if that initial kind of contact is negative, it can really affect your ongoing care and treatment.
Yeah, we're going to hear more about that throughout the show today, because it's not just Starla. That has happened to others, like you say. Before we go much further, a lot of people won't know what Sanctum Care Group does. And I know that a piece of all the work you do really focuses on women and women who are living with HIV. So give people a sense of the kind of work that takes place there.
Yeah, so one branch of our organization really does focus on women specifically who are pregnant and at risk for contracting HIV, or they may have HIV and not be on medications. So our services target those women to increase prenatal engagement, to get them on the appropriate medications. But I think more importantly, our programs are geared to meeting the basic needs of those women. Unfortunately, over 70% of the women that we work with who are pregnant are also homeless. Over 80% of them are struggling with injection drug use. And so we recognize that need kind of very early on in the work that we were doing with Sanctum Care Group, and have designed a few different programs to target the needs of that population. One, which is inpatient, which is Sanctum 1.5, and that's a home-like environment with 24/7 support for those moms.
Very, very much a home-like environment. Yes. I have dropped off donations. It's a house.
It's a house.
And people are hanging out and caring for their kids and
with a big
doing what
furry
you would
dog.
do. Yeah.
Yes. And then, unfortunately, it is only a 10-bed home. It services the entire province. We have battled long wait lists for a very long time. So we did launch PORT, which is our prenatal outreach and resource team in Saskatoon, Prince Albert, and Regina, and that is a very intensive case management approach where we work with any woman in our community who is at risk of having their infant apprehended at birth, essentially. And we provide wraparound service and support to those women as well.
Okay. As we were learning about just how high the numbers are in Saskatchewan, there was, some figures provided by the Public Health Agency of Canada. There was also this 2-year analysis that was released, and the lead researcher was someone who I got to sit down and have a conversation with. It's her conversation alongside Toby Esterby is our podcast this week. This is Saskatchewan, and we wanted to share that with people here. So Dr. Kara Spence is the lead researcher. She's assistant professor in the Department of Medicine at the University of Saskatchewan, and Toby Esterby is chief operations officer of the Westside Community Clinic. That clinic is on the front lines of HIV care in Saskatoon. They have around 800 patients with HIV right now.
There's a few different things that really illustrate the urgency and the seriousness of the situation that we're in. First of all is just the number of new cases. The teams interact, like Kara said, like it's not that we're seeing a case a week, we're seeing several new cases every week, week after week after week. And that is a spread of infection that shouldn't be occurring, that it's completely unnecessary for that to occur if we had a plan and resources in place. The other thing that happens is that we really see at Westside the Venn diagram, as it were, of HIV care and poverty and proper primary health care. And if you don't look after one of those things, all three of those things come into play and really start getting affected. So we're really struggling, with folks that are trying to address HIV. They're trying to take care of themselves. They're trying to make it to their appointments. They're trying to do all of these things. But the social determinants of health that are affecting them are just so astoundingly crushing that they can't address their health needs. They need to worry about food security. They need to worry about housing. They need to worry about family relations. They need to worry about healing trauma. And after all of those things, then they may be ready to work on their HIV diagnosis. And in the midst of that, when we're seeing that the infection spread in community, those things are compounding the rate at which we see those infections occurring.
Dr. Spence, you started nodding your head when he mentioned poverty, and you said that it's women, and it's often being spread through heterosexual sex. Can you tell me more about that?
Well, that's a new trend, and that's a troubling trend. When it's heterosexual transmission, your risk factor is having sex, having unprotected sex, and that may be with a partner or a committed partner or otherwise. So, when you're looking at HIV is often related to poverty or social determinants, globally. We don't see these kind of trends globally anymore. HIV is a chronic disease now. It's easily managed, and there's excellent treatment available where you can live a long and healthy full life. But as Toby mentioned, when you're dealing with deeper core issues like housing and food security, your health often comes secondary, and it increases your vulnerabilities to looking for ways to find security, to find resources, to find money and funds. So without addressing these core root issues, then HIV in Saskatchewan, which is really quite embarrassing that we're seeing these kind of trends and rates.
Toby, do you find it embarrassing?
I really do. In the context of Saskatchewan, we are a wealthy province in a wealthy nation. We're a G7 country, and we hear often about how we are one of the more economically stable and prosperous provinces in the Dominion of Canada. And yet here we are leading the world in incident of HIV rates. Those two things shouldn't exist in the same place. We should have enough wealth in our province, in our communities, in our country, to make sure that those who do not have can have their health care looked after. So yes, I find it extremely embarrassing. Number one, that we don't have a plan. And number two, that the folks that are trying desperately to do this work, if you ask any organization that works in HIV in the province right now, the first thing they will tell you is that they are under-resourced. So we need to address some really core issues before we'll even start to see this turnaround.
I'm sure there's a lot of people listening right now who are trying to wrap their heads around the fact that it is decreasing around the globe and not here.
Well, and not here, exactly. So these national trends, increasing trends, really, I mean, we're responsible for that here in the prairies. And having, like, gender is a social determinant of health. So with women, young women being adversely impacted, there's so many residual impacts of that with children and families and communities. So it's not just the woman that gets a diagnosis. The whole family and the whole community also feels the impact of that. So we really do have to go right to the root of this. You know, the social determinants, having women as increasingly marginalized and vulnerable is, again, a target or a beacon for support that needs to be put in place.
We keep talking about, well, I've been talking about the rates of diagnoses, but how often are people dying in Saskatchewan of the virus? Like, you know, a lot of people know that this is a virus that can be treated, that people can live long and healthy lives with HIV, but what is that the case?
So, like, I guess I need to back that up a little bit to make the answer make sense. So first of all, HIV is a completely treatable chronic disease. There's no reason to die of AIDS. There's no reason anymore. There is ample care. There is ample medicines. The science around HIV has advanced so much, and it's off of people's radar because out in public and those listening on the radio right now, some are probably surprised that this is still a thing. Yet here we are in the midst of what we characterize as an epidemic. So we have to back that up first and recognize that HIV care has progressed to the point that nobody has to die from HIV. Nobody should die from HIV. And then I'm going to tell you that we lose somebody every week.
Mm-hmm. Every single week.
I can give you the data on that. So we've had more deaths in this population in the last 4 years than the previous 10 years combined. So the deaths that they're seeing frontline is, they can't even keep track. Every time I do these quarterly reports, that death number increases and increases.
How do you personally feel when you say that, Dr. Spence?
Oh, the moral despair frontline with the providers and even with those that are impacted is great, is really astounding. It's hard to work in this field and continue to work in the field knowing that these rates increase, that there doesn't seem to be a prioritization or an adequate resourcing to address, no plan. It just seems like we've accepted this as status quo, and it's not okay. This isn't acceptable. So it's very hard, and you see that moral distress across the whole scope of this work.
Toby, how do you process this?
Some days with a calm mind and some days with flat-out anger. Like when we see folks that we get to know on a first-name basis pass away unnecessarily, it's hard on the heart, and it's hard to justify working in a system that creates that death. And I want to be crystal clear in that, is that we should be able to build a system that creates the ability for people to remain well. But our lack of a system right now is creating structurally full-blown AIDS. HIV should not ever become full-blown AIDS anymore. There's medication. We were talking before, one of the most profound things that came out of the 2-year study. We were sitting in a meeting, and one of the infectious disease doctors said to the room that she would choose an HIV diagnosis over a diabetes diagnosis any day of the week because it was much easier to manage HIV.
With me in studio listening is Caitlin Roberts, the Executive Director of Sanctum Care Group. Quite a bit to take in there, but none of that was new to you, Caitlin. There's a few questions I want to ask you related to what both those guests brought up. There's no reason to die of AIDS anymore. Are you seeing people pass away because of AIDS and the work that you do?
I mean, we had 3 people die last week of AIDS. So unfortunately, it is a very common occurrence for us on the front lines to see patients dying of AIDS. I mean, certainly Sanctum, we have palliative beds just for that. And And we're not seeing things get better. We're certainly seeing them get worse. And, like Toby said, we live in a country with the best health infrastructure in the world. And so what does that mean for us as a community when we have the best health infrastructure, but yet we continue to see people die of something that is 100% preventable?
3 people just last week. Mm-hmm. Do you feel moral despair? Do you feel anger?
I would say yes. I mean, it's hard not to. I've worked in this field for a very long time, and it is very discouraging because there is a lot of incredible work that does go on in this community. There's a lot of great initiatives, but we're not winning. Unfortunately, we continue to lose. When we look at the intersection of the complexities that this patient population is looking at, it certainly speaks to why we do see the increasing rates that we do. I think it's important for people to understand when it comes to treating HIV, it is a very simple disease to treat. If you do not receive treatment and you become AIDS defining, that's when things become problematic, not only for the individual, but for our community as a whole. Because when you're on treatment, even if you continue to engage in high-risk behavior, you're no longer passing on that virus.
Right.
And you can live a long, healthy life. If you are not on medications, you will eventually progress to AIDS and succumb to that disease. If you're on medications, again, you'll live a long, healthy life. But what we're seeing is an increasing number of people who are AIDS-defining in our community, people who are being diagnosed, and AIDS-defining at the same time.
Because they hadn't sought care.
Correct.
And that kind of links back to what we first started talking about, hearing Starla's story of what it was like to get that diagnosis. She luckily found a community, found a way forward. But a lot of people, because of previous, some really terrible experiences with the healthcare system, will just not go back to a clinic. Am I understanding that correctly?
100%. And it's also, we need to recognize too that a lot of the patients that we work with, there's competing priorities. When you're living on the street, when you don't have access to housing, when you don't have access to food, rates of violence in our community, especially against women, we see that at 1.5 and through our PORT program, 60% of women report it. So there's a lot of competing factors. And when you're just struggling to kind of survive, taking medications can be really difficult. The average Canadian is 50% compliant with their medications. And we're asking a population who's struggling with homelessness, with exposure to violence, with mental illness and addiction to be 98% compliant.
How do we compare to the rest of the world? You just got back from a global conference on HIV/AIDS, right?
I just got back from Amsterdam. It was a global HIV knowledge exchange, and I felt alone in the room. The conversations that I wish we were having here are happening globally, where we're talking about optimizing living with HIV, optimizing your medications, aging with HIV. We're simply trying to keep people alive in Saskatchewan. And I think it's really important for the general public to know, obviously, that you can live a long, healthy life. But obviously, the social net that we boast in our community is not enough. And we're certainly seeing many people fall through the cracks.
If you felt alone at that conference, is that a Saskatchewan thing? Are we really even just standing out within Canada?
I think globally we stand out.
Like the province of Saskatchewan, not just Canada, but like us here specifically in this province.
Yeah,
for failing.
For failing.
I'm speaking today with Caitlin Roberts. She's the executive director of Sanctum Care Group in Saskatoon. We're going to hear more on this coming up. If you have thoughts on what you're hearing so far, give us a call, 1-800-716-2221. You can also email bluesky@cbc.ca. Caitlin, 1,500 people in the point in time count, which is tracking people who are homeless. It's just a snapshot. It doesn't capture everybody, so that number could likely be higher, I guess. I mean, you're connecting the dots, I'm sure, on that, hey?
Yeah, and I mean, we know that people living with HIV who are homeless without support have an average life expectancy of 5 years. And so when I hear those numbers, while they come as no surprise, they certainly are, directly related to what we're seeing in the world of HIV as well.
Okay. You're listening to Blue Sky here on CBC Radio 1, 94.1 FM in Saskatoon, 102.5 FM in Regina, 540 on the AM dial. You can join the conversation today, 1-800-716-2221. You can also email bluesky@cbc.ca. Heather joins us on the line from here in Saskatoon. Hi, Heather. Welcome to the show.
Hi. I just have some thoughts, mostly about Mo and his recent decision to disallow agencies to go into schools and public centers, especially schools, to talk about sexual health and prevention and healthy relationships and consent. When we're dealing with HIV and chlamydia and all the those determinants that were mentioned, those are all late interventions and dealing with it after the fact. And there are agencies like Out Saskatoon and Sexual Health Services and Sexual Assault Centers, like where I used to work. We would go into schools and we would talk to kids about sexuality and healthy relationships and making choices and trying to do more preventive work and abuse prevention and helping young people especially learn what is appropriate, what's right for them, how to make choices, and preventive practices using contraception and talking to parents and understanding sexuality, understanding how you get diseases and how we can prevent those things. So I would really like to see our government take action to allow those agencies to go back into schools and make a difference at a younger level where we can maybe do some prevention work.
Heather, thanks for calling. I really appreciate that.
Okay. Thank you. Bye-bye.
Bye. That was Heather joining us in Saskatoon. Caitlin, I don't know if you want to touch on that, but I am curious to hear your perspective of the trends that you're seeing in your line of work, hearing from Dr. Spence that, noticing this shift and seeing more women, transmission through heterosexual sex. What's your take on how HIV is spreading in the community?
Well, certainly, Dr. Kara Spence, the data is trending, with women. For us as an agency, women of childbearing age becomes an increasing concern when we look to, prevention of vertical transmission of HIV, and that's transmission mom to baby. Mm-hmm. I think it's important for people to know that with medications, if you were pregnant and you're on medications, the chances of your infant contracting HIV are less than 2%. If you are not on medications, that jumps to around 15 to 25%. If you are someone who is not positive but is at risk of contracting while pregnant, the chances of your infant contracting HIV skyrocket. So when we talk about prevention, it also feeds into, for us, the vast majority of women that we work with in terms of preventing vertical transmission are women that we know are at risk of infant apprehension at birth, and that is, typically related to homelessness, a substance use disorder, or having previous children in care. Yeah. And so we have, unfortunately, seen vertical transmission in our community, and we're seeing it rise. Our organization, which is very small in terms of Sanctum 1.5, we admitted 2 women postnatally, so they had already delivered their infants, that were positive in fiscal 22-23. So again, 100% preventable, but...
So that's the story that you're sharing at the global conference versus what other countries are talking about.
Yeah. And it's multifaceted in terms of the reasons why. A lot of women in our community, there's a vast amount of mistrust in our health sector, but also in the social services sector. A lot of women who've been impacted negatively by involvement with child welfare, having their infants apprehended at birth. And I think, Leisha, you and I would both agree there's nothing that we wouldn't do to keep our baby. And so if it means keeping that pregnancy a secret, we're going to do it because that's the only thing that matters.
Yeah. I want to go back to the conversation I had with Dr. Kara Spence, the lead researcher on this 2-year analysis, and Toby Esterby, the Chief Operations Officer of the Westside Community Clinic in Saskatoon. And I asked both of them if this is because of a lack of political will to tackle the problem.
Yeah, it's a lack of prioritization, political will, and resourcing. Really, there are solutions to this. There's global targets, 95. They used to be 90, 90, 90, and there are clear measures for those 90% markers. And they've actually increased to 95% of those that are living with the virus are aware of their diagnosis, are seeking treatment, and are suppressed. So, basically no active virus in their body, just, living a healthy, normal life. Those are real targets that are being met all over the world. And we're nowhere close in Saskatchewan, so you absolutely can, even nationally. You look at British Columbia; they're closing HIV/AIDS units because they've got their numbers. They're nearing those 95% targets, and what they did was just hammer it. That's what you need to do. You just need to put the resources and the prioritization in place, get the virus down, really get a handle of it, and then it's manageable. You can manage this virus.
What kind of resources are we talking about, Toby? What would be ideal at your clinic? What do people need who are working with folks who have this virus?
Well, there's some on every level. The first notion is to make sure that we are treating HIV as a primary health care concern. So we need to resource it with clinical knowledge. We need to resource it with doctors that can prescribe the medication. But then we need to provide the supports around the folks that are accessing that care. So that looks like outreach teams. That looks like case management teams. That looks like supports to help folks navigate their journey with HIV. It looks like great pharmaceutical support that is connected to those primary healthcare teams. And it looks like a system of organizations that collaborate together to make sure that fewer and fewer people are lost to care. We recognize like HIV treated is no problem at all. You can live a full and healthy life unaffected, and with no virus in you at all, you are not infecting anyone. So you can lead a full and healthy life. But when folks are lost to care, they may be off of their medication, or they may be communicating that infection to others. So that's where we need to really work to make sure that we have fewer people that are lost to care. What we need for that is boots on the ground, people doing the work, many, many more people doing the work, properly resourced, so that those folks can have a connection to the care that they need throughout their journey with HIV.
And Dr. Spence, where do those resources need to be? I'm curious about the differences between, say, Saskatoon and Regina, and how different the rates may be versus more rural communities in Saskatchewan.
Yeah, and we can't forget about Prince Albert and the north as well. So I agree with Toby. The boots on the ground. Really dedicated care for people, and then to take one step further, it's the prevention of the virus, and that's the social determinants. We must adequately resource our social structures, our social systems. Housing is just a critical piece of so many connected and connected to so much in terms of health and those determinants of health, structural even determinants of health. So how to allocate resources? Well, we don't really even share data across jurisdictions, so or standard measures. So we need to really start with understanding what the rates look like in different communities and different urban centers. Really, it's a provincial scope. We have to ensure that housing is affordable and available. We need to ensure that resources are being allocated equitably. Even in Saskatoon, everyone just sends them to Westside. There's really not a plan or strategy. They just send them to Westside, and yet Westside Community Clinic doesn't receive HIV allocated funds from the government. So what we need to do is really look at where the highest rates are, like the increasing, where the gap of that care is, and resource it. So not only clinical care, but also these social determinants such as housing.
Can you tell me about some of the stories you've heard from people who are living with the virus? Like we heard from Starla off the top. and she shared a bit of what it was like to get that diagnosis and didn't feel cared for, in the hospital. What are some of the stories that stay with each of you? I'll start with you, Dr. Spence.
Oh, we did talk with people who were living with this HIV diagnosis, and it was really hard to hear their stories because Starla's story is common. Stigma is probably the biggest factor that prevents people from seeking care in the health system here in Saskatchewan. Westside has a tremendous team of really responsive and caring providers and individuals. Entering any healthcare system or structure or building is often very traumatizing for people because of the poor treatment that they've received. Getting that diagnosis, we have to be really kind and compassionate and supportive to give that diagnosis. It's not just something you throw out there on your way out the door, for sure not. Having peer support workers or people who also live with the diagnosis to be, part of that care team so that they really understand what that might feel like to receive that diagnosis. Just the fear and stigma that people live with is definitely a preventative factor from people seeking care.
Toby, what are some of the stories that have stood out to you?
What stands out for me with the stories is that there's both sides of it. There's some really, there's some folks that have some really positive stories about, dealing with their diagnosis and working through that and finding that stability and then, becoming a leader in community, becoming a peer, becoming someone that folks can go to help with that navigation through HIV diagnosis and through starting your treatment and through starting care and meds and everything like that. And there's so many people that I've met along the way that are just inspiring in the way that they approach life with such simplicity and gratitude and grace in the face of a system that really isn't built for them to access care easily. They navigate it with such grace, and it's so inspiring. The flip side of that is, speaking to the social determinants of health and how important that is around the prevention piece, it shouldn't happen that a conversation occurs in our clinic where someone that we know well now also has added to their plate a new HIV diagnosis. But now that they have an HIV diagnosis, maybe we can get some more resources to help look after the social determinants of health. So the resources are after the diagnosis, where the prevention piece could have prevented the illness, could have prevented the infection. And that's just such a sorry comment on where we are resourcing the system. We are heavily resourcing emergency rooms, and we're heavily resourcing this reactionary care provision, where if we could just get upstream of that HIV diagnosis, we would literally wipe this out. You look at BC, you look at areas around the world where they've reached those 95 targets. HIV disappears. It can be a completely managed chronic disease. There's no reason that we can't get there.
And what exactly does that mean? The 90, 90, 90, the 95, 95, 95. What exactly does that mean?
Mm-hmm. So those are global targets set forward by the United Nations AIDS Commission. Been in play for, probably at least 20 years. And like I said, they used to be 95, 95, 95. And now we're doing so well globally, they've increased to 95, 95, 95. And like I mentioned, it means that 95% of people who are living with the virus are aware of their diagnosis. 95% of those are accessing treatment. And 95 of those are virally suppressed, meaning that they're living a completely healthy, normal life, and the virus is not active in their body, which means they can't spread it to other people.
For quite a few years, I thought the story in Saskatchewan was that HIV was spreading primarily through intravenous drug use. And obviously that story has changed. But I'm wondering what you would say to people who think, well, this doesn't affect me. This is about people living in poverty, possibly who have a substance use disorder. This isn't about me. What would you say to that individual?
So this is the problem with the current epidemic, that it's heterosexual transmission, any kind of sexual transmission. So if you're someone who is having sex, you are at risk. So it's not a poverty. You don't have to be in poverty as a criteria. You don't have to inject drugs or do drugs as a criteria. It really is, now that it's moved into that level of risk factor, it really does affect everyone. And we have seen diagnoses of people who are just like you and I, who, for whatever reason has had, unprotected sex and now live with the diagnosis.
And is that just because, too, that the rates are just so high in Saskatchewan?
Exactly. There's so much virus in the community that it really affects everyone.
And I think the other piece there, it's HIV, it doesn't affect me. It does. I don't know anybody with HIV. First of all, they probably do know somebody with HIV. They just don't know that they do. And then the second piece, it doesn't affect me in Saskatchewan. Has anybody had any trouble accessing a doctor or had to wait at the emergency room? Has that happened to anybody? Because that's an impact. We have folks in the province that are accessing hospital beds and accessing the emergency room and accessing palliative care and accessing all of these things in the healthcare system that shouldn't have to access those things, because HIV care should be properly managed and you should never ever have to go to the hospital for your HIV care. So that's the impact. That's one of those system impacts that affects all of us. We all need to have a vested interest in making this better and making the system work better. It will have an impact throughout the system. It will have ripples of impact throughout the system, ripples of impact through generations. And that's maybe back to one of the biggest things that breaks our hearts these days is we're seeing young mums. We need to get to those young mums in time with that HIV diagnosis so that we do not have a baby born with HIV. That should never, ever happen in this world.
But
anymore.
It is happening in this province, in this city. Some women are diagnosed with HIV in pregnancy because it's now part of the standard routine laboratory tests. But, how long was she living with HIV before she had that standard test? So, just young women. Young women are particularly vulnerable to this virus, which really troubles me.
So what now? Now that you have this analysis, you have a clear picture of what HIV looks like in Saskatchewan or in Saskatoon, and then how that relates to other communities in the province. Now what? What are you hoping this data reveals, and what is the call to action?
Well, first and foremost, thank you for having us, because it's drawing attention to, because this is, although our rates are starting to chunk up again, this isn't a new story in Saskatchewan. So to have renewed attention to this issue, I hope will draw some political will and prioritization. We do have a really strong group that works well together, that I think, given the diversity of that group, can come up with some sort of plan to present to the government to say, hey, this is what we think. Part of that would be a provincial program where many people move through communities and centers, urban centers, and how many of those are lost to follow-up or getting care elsewhere, we don't know. So a provincial scope on this matter would be super helpful.
Yeah, I think my hope for the what now is that I hope this study and these conversations and the continued conversations start to light that fire. Start to light that fire of awareness throughout the province, not just in our circles of folks that work with HIV, but start to light the fire of folks that are hearing this and saying, how is this still a thing? How is this happening in my province? We want to light that fire and get people talking and understanding HIV in its modern version. Stigma-free, completely manageable, absolutely just a chronic disease management piece, and living a full and healthy life. We need to light that fire so that people are having that conversation. And then we need to light the fire of the folks that are doing the work at the ground level too. There's, like we've both said, there's amazing teams in place, and everybody is burning
out.
It's so much work. It's so overwhelming. It is. I tell people often that some of our work is the most frustrating and rewarding work that I've ever experienced in my life, because you're constantly banging your head against the system. And then once in a while you get something that's like, oh, thank goodness we got that to work.
That is Toby Esterby, Chief Operations Officer of the Westside Community Clinic, and Dr. Kara Spence, the lead researcher on a 2-year report. She's an assistant professor in the Department of Medicine at the University of Saskatchewan. We did put in a request to speak with the Minister of Health for our show today. No one from the ministry was available to be on the show, but they did send a statement, and it reads, "The government of Saskatchewan is concerned about the high rates of HIV in our province. HIV is preventable and treatable, and the province remains committed to improving access to healthcare services for individuals living with HIV/AIDS. This is why our 2024-2025 budget includes an increase of $1.5 million to improve provincial testing capacity and expand access to testing for all sexually transmitted and blood-borne infections, including HIV. Annual ministry funding of approximately $7 million supports HIV services delivered by the Saskatchewan Health Authority and community-based organizations. Medications used to treat and prevent HIV/AIDS are 100% covered in Saskatchewan for beneficiaries who meet the medical criteria. The only way to know if you have HIV is to get tested. This statement states, many people who are diagnosed and start treatment early go on to live healthy lives. Simply knowing if you have HIV is the most powerful thing you can do to reduce its spread." That is the statement we received from the Ministry of Health. With me here in studio is Caitlin Roberts, Executive Director of Sanctum Care Group. Listening to me read that statement, is that adequate? I want to put the same question to you that I put to Toby and Dr. Spence. Is there the political will in this province to properly tackle HIV?
Yeah. I mean, I think, and it's important to understand that we are seeing increasing trends in women. But Saskatchewan is also unique in terms of our rates related to injection drug use. Mm-hmm. There is a large population in our community that is not engaged in care. And so while it is really important, obviously, to have increased access to testing and treatment, in terms of preventing further transmission, we also have to have strategies to engage a population that has been largely left to kind of languish in our community without the support that they need to manage their HIV. We just launched a new program that targets that patient population, patients who are AIDS defining and not on medication. It's been a month, and we've, over 16 people referred and now on medications.
So how do they get referred to you? How do you actually connect with that population?
So they're referred primarily through physicians. Yeah. So physicians who have patients on their caseload who are not, on medication and are obviously AIDS defining, they can be referred to our program. These are also patients who are living in homelessness, right? And I can't stress that enough. We have a patient population that is struggling immensely with homelessness and also with addiction, with not a lot of resources to support them in any form of stabilization or even recovery. And without those supports, we will continue to see people struggle in our community. What we're doing isn't enough, obviously, or we wouldn't be sitting with the highest rates of HIV in the country.
I want to go to another caller. So Dorothy joins us on the line in Saskatoon right now. Hey, Dorothy, welcome to the show.
Yes. I would just like to know, in all this researching, has anybody done a correlation between the sudden decision by the provincial government a few years ago to no longer pay the rents and whatever other subsidies that were paid for those who, for whatever reason, are unable to manage their own monies and were on, for lack of a better word, a welfare support where their landlords were paid directly so that people actually had a place to live. That disappeared. We suddenly have a huge influx, I don't know if that's the right word, growth of people on the streets, people who are now homeless because they have no place to go home. And how does that enlargement of homeless population, how does that correlate with the increase of HIV and AIDS. And I just want to add another thing to that. This government thing that we just read, they will identify if you have. Maybe they should put their emphasis on not discovering who has it, but in prevention. And I leave those with more knowledge than I. There are definitely ways to prevent this rather than just discovering it.
Yeah.
I will stop talking now.
Dorothy, I so appreciate you calling. Thank you. Some interesting points there. Do you want to touch on that, Caitlin?
Yeah, I will say this. Our strategy as an organization, while our goal is always treatment, our number one strategy for getting people on treatment is getting them housed.
Is getting them housed.
100%. That is our first line of defense, is to get somebody into housing. That is the gateway to medication.
So how do you get someone housed? Like, how do you do that?
Well, we do. We have it's a pillar within our organization. It's an important piece of, probably the most critical piece that we do as an organization. It's boots on the ground. It's a lot of hard work. It's creativity. It's working through a trauma-informed lens. It's doing things. I think that people would maybe not attribute to healthcare, but housing is healthcare. And we need a solid investment in housing. And the caller is not incorrect. I'm sure if someone did the research, there is a direct correlation between what happened with the CIS program and the increasing rates of homelessness that we see in our community, for sure.
We did get a voice note from a woman named Trina, who I actually know has done some research in this area. She appeared on our show. She was talking about online dating, but she's done a lot of work between the intersections of sex work, poverty, gender. So let's listen to her thoughts after she listened to the podcast.
The rates of disease and also the way that they are distributed are never random. And as is the case in Saskatchewan, they reflect growing inequities. They reflect pre-existing inequities that are just being exacerbated by different kinds of economic and political decisions that are being made. And in many instances, it is an indication of social suffering. There's a lot of research from many parts of the world that reflect this. Rates of disease are not just the product of individuals making certain behaviors in their own lives or poor lifestyle behaviors. It's a reflection of endemic rates of poverty, racial inequity, and many other decisions that are being made by the current government that are not really for the benefit of the whole of society. And so that is one of the most distressing aspects of the rising rates of HIV right now in Saskatchewan.
Caitlin, what do you think?
She's not wrong. We see that every day in the patients that we serve, and for some reason, there's always this kind of moral high ground that comes into play when you're dealing with infectious disease or injection drug use, and there's somehow this conversation around choice. I can tell you, working with many of the people that I do work with, this was never a choice for them. There is a significant amount of trauma in our community, a significant amount of childhood trauma. So you cannot tell me when, you're put out on the street at the age of 6 that it was ever a choice for you. And we have people coping with immense trauma through the use of drugs. And we're not offering anything better. There's no access to services and supports to recover from trauma or to even have your basic necessities met. And that's obviously reflected in our homelessness count here today. It is, and it sounds cheesy, but how we treat our most vulnerable is a reflection of who we are as a society. And I think Saskatchewan is failing deeply.
I want to share an email that Laureen sent. Laureen writes, I'm listening to Blue Sky today about the epidemic of HIV and homelessness. I am overwhelmed. There must be something I can do step by step to focus on making the system work better. Do you have ordinary people, what can we do? What are day-to-day citizen steps that I can take? So she writes, number 1, lobby who? Number 2, put my time and money toward what? Number 3, how do I help? How would you answer those questions, Caitlin?
Well, I think there's a lot of different answers for those questions. What I will say is, and, obviously I represent my organization, but, Sanctum Care Group has very good data to support the interventions that we have, not only in engagement and getting people on medications, but improving their overall well-being through housing, through support, through access to addiction, treatment, all of those things. It is holistic in nature, and without a strategy that is holistic in nature, we're going to continue to see, increasing rates of HIV. Our organization is embedded within Westside Community Clinic, and that kind of combination of integration of the health and social needs of this patient population is incredibly important in terms of delivering really good outcomes. We've seen a shift in how HIV is managed in our community, and not all of the strategies are aligned with what we're seeing in our community, and I think
what do you mean by that?
Well, I mean, I was an HIV case manager for many years, and we had very intensive approaches to managing HIV. I think there's a bit of a shift now, and we're coming out of a pandemic, and there's been lots of kind of turnover within our local health authority that I think has impacted how we prioritize funding, how we prioritize resources, and a lack of data.
Which is why Dr. Kara Spence and the team felt so strongly about coming up with this 2-year analysis.
Yes.
To have the data, and to say this is what's happening. This is how we compare. Yes,
the data for sure on the patient population, but the data to support the interventions is also, and that's one of the recommendations of the of the evaluation was, there is lots of good work happening, but there is a lack of coordination and a lack of data. And data should always inform our decisions as average day citizens, as government. What are the effective strategies? Where is the data to support them? And how do we expand the strategies that we know have impact?
I want to take the last minute to allow you to talk about a story or something that you hold on to that gives you hope, that keeps you working, keeps you going day to day, because there are stories of survival and resilience.
There's so many. I think for me and for the individuals I work with, an easy one for me to talk about is where my office is, and it's at Sanctum 1.5. And, I see
a home office. Sanctum 1.5.
Yes.
That's awesome.
Yeah. And, I get to walk through those doors every day and see women holding their babies, breastfeeding their babies, loving their babies. And I get to see them leave and go into community and go into post-secondary. I think that, if we provide people with the basic necessities of life, there is no telling what they can do. And I think, we have an opportunity to do that as a society. And I think, it's not just Sanctum. There's many organizations that could share incredible stories about when you put the right services in place, and you have, the combination of health and social care in a setting, the outcomes are absolutely tremendous.
Caitlin, so good to have you as a guest today. Thank you.
Thank you.
That is Caitlin Roberts, Executive Director of Sanctum Care Group. I'm Leisha Grabinski. You've been listening to Blue Sky here on CBC Radio 1. If you're interested in hearing more from Dr. Kara Spence and Toby Esterby, that is the podcast episode this week for This is Saskatchewan. You can find it on CBC Listen or wherever you get your favorite podcasts. Give us a follow and then you'll know each time a new episode drops.